Yeah, why don't we get started?
Wonderful. So, good afternoon, everybody. Delighted and honored to welcome Dr. Frank Harrell, who has generously offered to give our Grand Rounds lecture today, as you can see, entitled Ways to Make Randomized Clinical Trials More Statistically Efficient. Dr. Harrell is a professor of biostatistics at the Vanderbilt University School of Medicine, where he's the lead biostatistician for the Division of Cardiovascular Medicine. In fact, his involvement in the study of cardiovascular disease spans 50 continuous years, starting as a college freshman at the University of Alabama in Birmingham, and including a 9-year stint at the Division of Cardiology at Duke. His contribution to the literature is truly remarkable and includes his work as one of the principal statisticians for the ischemia trial. He has also recently joined the Orbita team at Imperial College in London as a senior consulting statistician. Importantly, he has been a vocal critic of many bad statistical practices that still linger today, and is an advocate for and expert on Bayesian statistics. Once again, thank you for joining us, Dr. Harrell.
And thank you, Arash, and thank you, Bobek, so much for inviting me. So it's a great honor to be here. Look forward to some lively discussion, and there should be something in the talk to offend almost everyone. So I'm going to start with issues that are related to power and sample size. Most people who have been involved in clinical trials know the answer to this question. What are the most common outcomes of clinical trials? The number one outcome is insufficient patient recruitment. And you may not know this statistic, that the median number of patients recruited in a cancer clinical trial is 0. So more than half of cancer clinical trials that are opened never recruit a single patient. But we usually don't have that much trouble in cardiovascular, but still recruitment lags what we hope. And then the second most common outcome is an equivocal result. Equivocal result is really not what you're seeking, because you need the trial to be worth the resources and time that it takes. And so what is an equivocal result? Well, you have some planned sample size and the result is not so-called significant. Whatever significance means doesn't mean very much. And what happens most of the time when we have an equivocal result is that the uncertainty intervals are wide enough that we really haven't learned anything. So I've seen many clinical trials where they have, say, a hazard ratio confidence interval that goes from 0.5 to 2. So the data are consistent with the treatment doubling or halving mortality. In other words, you don't really know anything, except that the money was spent. And that's not a good thing to learn. What are the most common causes of equivocal results? Well, number one is an over-optimistic power calculation. And that is because we use effect sizes that are larger than clinically relevant. And the result of that, by pinning your clinical trial on a hope and a prayer, is that if the true effect is only clinically significant, say it's only a 20% reduction in MI probability, you're likely to miss that clinically relevant treatment effect. Another cause of equivocal results, a very large cause, is a fixed sample size. And to me, it's really a shame, and I've felt this way for about 30 years in cardiovascular trials, that if you have a p-value of 0.08 at the end of a planned sample size, to call that a negative study, that's not really a good terminology to call that negative, but we usually do. So to call that a negative study is really a really sad thing to have happen, because you might have had a definitive study with a few more patients, or maybe 100 more. And so a fixed sample size is a major cause of equivocal results that are not very informative. And then we also lose power. And one of the ways we lose power is statisticians have sold researchers a bill of goods about type 1 probability, or alpha. So this is something that you hear as if it's a religion, that you have to control alpha. And most of the statisticians that have taught you that never really stop to think what alpha is and isn't. And I think this is a major problem. And so if you believe that alpha is something that should be controlled when you're taking multiple data looks, let's say you're doing a sequential clinical trial, that controlling alpha is going to make you conservative. So you're trying to protect yourself against something that you're really not interested in protecting yourself against, but it is lore that's handed down by statisticians for the past 100 years that we should pay attention to alpha for some reason. And then another major reason of having equivocal results is having an insensitive outcome measure. And so what is the problem with sample size? Well, we need, in the traditional way of thinking, we need a final sample size. And part of the reason for that, besides budgeting, is you need to know when the alpha is spent. So you need to have something to spend the alpha against. In reality, sample size calculations are voodoo, and I've thought that for at least 2 decades. It's one of the most distasteful exercises that as a statistician I ever get asked to be involved in. And it really is a game that really boils down to a scientific way of stating what a budgetary restriction was. And it sort of blesses the budgetary restriction in a false scientific cloak. And a big problem with sample size calculations is you have to know 4 things to derive a sample size. You have to know the type 1 probability alpha, the type 2 probability beta, or 1 minus the power, the effect that you don't want to miss, delta. And then you either need to know the standard deviation of your outcome if it's a continuous outcome, or the event incidence if you're doing an event study or time to event study. So to know those 4 things simultaneously is actually very, very hard. And so we make them up and we hope for the best. Now contrast that with the way physicists approach research. They say we're going to experiment until we have an answer. And that to me is science. There's nothing unscientific about what physicists do. They usually don't have sample size calculations. And physics doesn't suffer from that. Do you need a sample size calculation? Well, if your budget is fixed, you do. But if you're using a Bayesian sequential design, you don't actually need any sample size. And of all the things you might think of as being a random variable, the sample size is my number one. I want to think about that as a random variable, and I don't want to nail it down as if it was a constant. With the Bayesian approach, the study extension is trivial and requires no penalty of any type. If you're doing a frequentist design, as we're taught, you get to the end and you decide you want to extend the study. Well, you've already spent your alpha. And so if you add patients, you actually pay a penalty. And the penalty actually, in some cases, makes the addition of patients a net negative. In other words, you could add 100 patients to the study and decrease your power because of the alpha adjustment needed for the sample size extension or re-estimation. But I think it's very logical to recruit more patients if a result is promising but not definitive, if you have the resources and time to do so. The analysis of cumulative data after new data are added, it merely supersedes the analysis at the planned study end. So in the Bayesian way of thinking, new knowledge makes old knowledge out of date and no longer relevant. And the beauty of that, it seems a very simple idea, and it is. The beauty of it is when you think about obsolete data or obsolete knowledge, you've got 200 patients now. What you knew when you had 100 patients is no longer relevant once you have the 200th patient. And it just makes sense that you want to supersede previous analyses. And so there's no multiplicity issue in the Bayesian paradigm. So your ability to add data is really unlimited. And then getting to the alpha, controlling alpha makes us conservative. One of the best kept secrets in clinical trials is if you're using a group sequential clinical trial and you have stopping boundaries so that you can tell the IRB that you're watching out for the safety of patients in the trial. The stopping boundaries are so conservative in the earlier looks that you might as well not even look. So you can tell the IRB that you're monitoring the safety, but you're so conservative, it's as if you're not. That's only a slight exaggeration. So what is alpha? It's often mislabeled as an error probability or type 1 error, but there's no error involved. So it got off on the wrong start back in 1920 or so, um, by calling it an error probability when it's not the probability of making an error. So it's a probability of making an assertion. So it's a probability of rejecting the null hypothesis, which means we're asserting an effect of the treatment. And it's nothing more than the probability of this trigger of asserting something. It's not the probability of making an error and acting as if a treatment works. And that's a key thing to understand, that most graduate programs in biostatistics are not teaching. And when I go to the best graduate programs and talk to their PhD students and ask them to define uh, a type 1 probability, they really have a lot of trouble with that. And it struck me that if you're going to be using that to guide how you do your research, you really need to understand the fundamentals. And it's not being properly taught in my experience. So alpha is not the probability of making an error and acting as if a treatment works. It's the probability of making an assertion of efficacy, rejecting the null, when any assertion of efficacy would by definition be wrong. So if you assume there's no treatment effect, what is your trigger probability for assertions? That's all it is. That is such a limited scope that is something that statisticians should be interested in for studying operating characteristics of test statistics, but as an evidentiary consideration, it really has no relevance. And the alpha probability is going to go up as the number of data looks goes up. So the more opportunities you have for data to be extreme, uh, the higher the type 1 probability. That has nothing to do with probability of efficacy or treatment effectiveness. So alpha includes the probability of things that might have happened, because when you're doing sequential testing, you have to adjust for looks you're going to take in the future. And after you get to those future looks, you have to adjust for looks that you took in the past, even if those looks were inconsequential. So those looks didn't make you change anything in the study, you still are paying a penalty for taking those looks. The penalty late is less than the penalty that you have to pay in the early looks. So even if you have very strong evidence of efficacy at a given time, the design had the possibility of showing an efficacy signal when there really wasn't any efficacy. So since you had a chance of asserting efficacy all along the way, that goes into the alpha probability. So you're penalizing yourself for things that might have happened, but once the data are in, all you need to concern yourself is with what actually did happen, not the opportunities we had for other things to have happen. And we certainly don't need to concern ourselves with what we learned at 100 patients when we're now at 200 patients. So controlling alpha leads to conservatism when there's multiple data looks. And by contrast, the Bayesian paradigm, the expected sample size, in other words, the number of patients at which time you would stop the study for efficacy, harm, or futility, your real sample size is going to go down the more often you look. So the less often you look, the more you're going to have a overshoot in the clinical trial. And if you look more often, such as every day or every patient, you'll minimize your expected sample size with the Bayesian paradigm because it doesn't know how to or need to adjust for multiple looks. So what should we control in a clinical trial? Well, we should control the probability of being wrong in acting as if a treatment works. So what is that probability? That's just 1 minus the Bayesian posterior probability of efficacy. And so the 1 minus the probability of efficacy is the probability of inefficacy or harm. And that is controlled by how the prior distribution is set in the Bayesian paradigm, plus it's controlled by data and your statistical model, your outcome measure, your sample size. So for example, if you had a hazard ratio for time until a cardiovascular event, your signal for efficacy would be to have a high probability that the hazard ratio is less than 1, indicating the treatment is protective. And that's given the current data and prior. And suppose as of a current data look, you had a 0.96 probability of efficacy, hazard ratios in the right direction. That means the probability of inefficacy or harm, which is just the complementary event, probability of hazard ratio is greater than or equal to 1, is going to be 1 minus this is 0.04. So that probability is the central probability you care about. That's the one you're going to carry along with you whenever you decide to act as if a treatment works by recommending the adoption of the treatment. If you had this level of evidence for efficacy, by definition, you have this probability of being wrong in acting as if the treatment works. That's something that's very noble to control. And it's directly a decision error. It's not an assertion trigger probability.
Frank, I have a question.
Yes.
So often we probably don't care about the hazard being less than 1. What do we want to define it more like the minimally clinically meaningful difference? What's the minimum, of significance to, the patient that might matter to the clinician? Just knowing something is perhaps efficacious will have a lot of uncertainty around that bounds, won't it?
Yeah, it's a great point. And what happens in classical statistics is we ignore what you just said, and we're just testing for a signal, and the signal is against a 0 or has a ratio of 1. So we're going to, with enough sample size, we're going to have evidence for an effect, even if it's very trivial. So what is different with Bayes is you would have the probability hazard ratio of less than 1, less than 0.95, less than 0.9, less than 0.85, less than 0.8. Go on and on. You could have 100 different levels of this. You get the evidence for all of those assertions. And so you can decide which one you want to emphasize in your study design. There is a catch that if your prior distribution is not too strong and you observed a hazard ratio that was exactly equal to the minimally clinically important effect, the probability of having that effect or better is going to be about a half. So to really have strong evidence that you have something more than minimally clinically important, you're going to have an observed hazard ratio that is more than clinically minimally important. So that's just a fact of life. So Bayesian sequential designs can gain power because of not having the alpha penalty and being directional. So when you do a two-tailed p-value, you have a multiplicity adjustment because you might conceivably find a mortality increase and you decide that you want to get a approval to be used in combat against the enemy. You have a way to kill the enemy. The treatment is so bad, and you want to have confidence that it wasn't just noise. So if you really think you might want to claim an increase in mortality, it makes sense to use a two-tailed test, which protects you in both directions. It's a multiplicity adjustment, whereas all the Bayesian probabilities we want to calculate, except for a similarity study, would be directional. So we don't care about possibly making a claim for increasing mortality. We're going to calculate the probability that hazard ratio is less than 1. And being directional, there's an instant power gain for being directional. You allow for infinitely many data looks, and then you can borrow information when there's interaction. This is a very subtle point, but if treatment interacts with something, we can't randomize enough males and enough females to make simultaneous statements about efficacy in males and females, but we can borrow information across males to females by having a prior distribution on the interaction term. And that means we don't need the sample size that we would have needed with frequentist statistics where the males and females have to stand on their own. So Bayes has a major advantage that interactions can be half in the model and half out of the model simultaneously, and that results in borrowing information from males to females. Now we turn to the outcome variable, which is a major topic in clinical trial design. And so the question here is, why do pivotal cardiovascular trials need between 6,000 and 10,000 patients? It's because they're using a low information outcome. They're using time until, say, major adverse cardiac events, MACE, or time until death. So that is a low information outcome. And it also it's an outcome that has a lot of ties in it, and you're not breaking the ties. So if you're using major cardiac event and you're counting myocardial infarction and death as two of your components in your composite endpoint, you're not distinguishing a small myocardial infarction from death. So you're not breaking the ties. And it's the failure to break ties that loses information, doesn't give treatments enough credit for reducing death. It may give them a little too much credit for just reducing non-fatal MI, but the statistical power suffers by not breaking these ties. And if you think about it, the vast number of trials that use time until first event, they are completely ignoring a death that occurs after a non-fatal MI. And that's actually unconscionable. So if somebody has a non-fatal MI, that's all that counts. The death that occurs a week or a month later is completely and utterly ignored. So what is the effect of this? Well, if you're going to estimate a hazard ratio within a good multiplicative margin of error, let's say you're going to estimate it within a factor of 1.2, maybe too high or too low, but it could be off by a factor of 1.2, which comes from the 95% confidence interval. You need 462 events to estimate a hazard ratio for time until major cardiac event. What if you had a continuous outcome like ejection fraction or blood pressure? Instead of needing 462 events to estimate a difference to within 0.2 standard deviations, you need 384 patients. Now that's a lot fewer patients than this, because to get 462 events may require 10,000 patients to be followed. So 384 is a drastic reduction. That shows the richness of information in a continuous outcome. If you're doing a crossover design instead of a parallel group design, for that same difference, for that same level of precision, you would need only 96 patients in a crossover study. So using each patient as his own control has a major advantage there. And then if your event incidence goes down, that means your censoring goes up. And if you look at the power for time to event, like in a Cox model, proportional hazards model, the more rare your event is, the more the power is similar to the power of a 2x2 table, ignoring the time until the event. So the power gets lower and lower as the event gets more rare, and you ultimately converge to the power of a binary outcome, which is your least powerful outcome that you could measure. This is an aside that relates to some things I'm going to say later, which is Peri-Procedural Mis. In the ischemia study, we had an incredible number of conference calls to try to figure out how to measure extent of myocardial infarction. And my take-home message for that is high sensitivity troponin is used every day, and cardiologists have not truly been able to figure out high sensitivity troponin. And we tried our best to come up with something that would measure extent of MI, especially when you have different labs involved with different assays. It was almost impossible. And then you get into all of this criticism because interventional therapy might have more procedural MIs, and medical therapy might have more spontaneous MIs. And how are you going to trade all that off? Well, nobody ever could do that. And I think we need to come up with better outcomes that make it kind of a moot point. So whatever the MI was, whether it was peri-procedural or not, if you measure the amount of damage that the MI did, and you make that amount of damage be your outcome variable, you'll go farther just settling this argument about how to treat the different types of infarction. And of course, you would treat death as worse than any level of MI while you're doing that. Now, the longitudinal ordinal outcome approach is going to be able to take a measure like that into account and give you a very meaningful analysis. So let's talk about what you need from an outcome variable. So you need to capture the timing and severity of the outcomes. The severity, I cannot emphasize enough how important that is, because if we're going to treat MI the same as a death, and hospitalization for worsening heart failure the same as a death, we are creating ties in the data that don't make any clinical sense and don't really map to what's important to the patient. So whatever we do, we need to take into account that there's terminal events such as death, there's non-terminal events such as MI and stroke, and then there's recurrent events. You could have a recurrent MI too, but a more common one is recurrent hospitalizations for congestive heart failure, for example. And so by taking all this into account and breaking the ties, we're seeking an outcome variable that has the most number of levels that you can possibly create. So the more levels of Y, the more you're making it like blood pressure as an outcome, which is going to give you optimum statistical power. The maximum power is going to occur when there's only one patient at each level of Y. So you have no ties in the data at all. So ties are our enemy in terms of statistical power. So we don't really need it to be that continuous, but that would be the ideal situation, is to have no ties in the data at all, which would be the case if you measure blood pressure extremely accurately. So what is a fundamental outcome assessment? Well, in a given week or day, whatever you want to choose as your time interval, what is the severity of the worst thing that happened to a patient during that week, for example? And so you need expert clinician consensus to rank the outcomes in terms of their severity. These could be from patient utilities, such as time trade-off experiments, willingness to pay to avoid bad outcomes, however you want to assess patient utilities, or just based on clinical expertise. You need the clinicians to agree on which outcomes are worse than which other outcomes. The spacings of the outcomes are completely irrelevant. So we don't need to know how much worse death is than a big infarct. We just need to know, we need to agree that death is worse than any infarct. Spacing is not used in the analysis. And so this approach, which is a hierarchical approach, worst event type of approach, you don't have to come up with additive weights. If somebody had multiple events in a given week, we don't need to derive weights for how to add up the multiple events. We're just saying if they had a worse event in a given week, we can ignore, for the most part, the less severe events that happened in the same week. Now, you can also extend this because the events can be graded. So if one of your events was stroke, you would want to have a stroke scale, or you at least designate a debilitating stroke from a non-debilitating stroke and make that two different levels of stroke in your outcome scale. And you can also code common co-occurring events as worse than an individual event. So if it was common, this is not the case, but if it was common that patients could have both an MI and a stroke in the same week, you could have a category that's worse than either MI or stroke, which is the occurrence of both of those in the same week, moves you to a new level. So you can handle co-occurring events with this ranking approach. So you can translate an ordinal longitudinal model to obtain all kinds of estimates that you're used to getting, such as time until a condition, like what's the expected time until hospitalization or MI or death? What is the expected time in a state? So you could say, what is the expected time in the hospital over the next 52 weeks? If you use a Bayesian model for this, the model that we favor is the proportional odds model, and you can extend that to what's called the partial proportional odds model. And when you do that, you can start asking questions that you might have wanted to ask for a number of years, but didn't have the tools to do it, such as, what's the probability that the treatment affects mortality differently than it affects non-fatal outcomes? So you may have a treatment that seems to improve function, and it doesn't seem to change mortality as impressively as it changes heart function or physical function. And you can actually do a formal assessment with this Bayesian approach to get evidence for whether the treatment is consistent and how it affects all the different levels of the outcome, going from non-fatal to fatal. And it also very elegantly handles partial information. So in each day or week, you can have censoring of your scale. So there might be ranges of the scale that you don't assess every week, and that might create interval censoring. So instead of having missing data, you no longer have missing data the way we usually have to handle it in a messy way. You just have partial data And I'll give you an example. So what does a longitudinal ordinal outcome look like? Well, in the simplest case, you've got dead or alive. So your outcome is just mortality, and 0 is alive, 1 is dead. And so if your interval of analysis is 3 weeks, your data for a patient who's censored at 3 weeks would have 3 zeros. So they were alive at the end of 1 week, 2 weeks, and 3 weeks. And then we have no further information. So the record stops right there. Someone that died at 2 weeks, they made it through the first week, and then they didn't make it through the second week. So they're a 0-1, and their record stops right there. That's a terminating event. Now, in the longitudinal binary logistic model that could be used to analyze these data, the odds ratio from that model is almost exactly equal to the hazard ratio from the Cox model. And if you put in a time-dependent covariate to allow for a time-varying treatment effect, the coefficient of that would also equal the coefficient from a Cox model with a time-dependent covariate. So this is grounded in something we're very familiar with, but how does it extend to non-terminating events? So this is a very common sort of outcome we have in cardiovascular studies. Everything is okay, that's a 0. Patient is hospitalized, maybe for heart failure, that's a 1. MI is 2, death is 3. So somebody who is hospitalized at 3 weeks, they're rehospitalized at 7 weeks, they have an MI at 8 weeks, and their follow-up ends at 10 weeks, they look like this. So they're going along fine, but then they needed hospitalization at week 3. They needed to be rehospitalized at week 7, but they were at home for these 3 weeks. Then they had a level 2 outcome at 8 weeks, that's the MI. And then they're followed a couple more weeks, and beyond 10 weeks, we don't know anything about the patient. So that's what your data would look like for that person. This is a little more general. And so this would be the first 7 levels of our scale are quality of life. So we're going to code it as 0 is excellent and 6 is the worst quality of life, but we're going to override that with an MI. We're going to override MI with a stroke, and we're going to override anything with death. So death is a 9, stroke, MI, then we have 0 to 6 as quality of life. So the quality of life varies. And we start off with quality of life level 1 at week 1, and then quality of life level 2. And so that patient's doing pretty well. And then at week 3, we don't collect the quality of life, either by design or we had missing. And so we know that at week 3, the quality of life is between 0 and 6. The outcome scale is between 0 and 6, if we know the patient did not have an MI, stroke, or died. So this is censored, interval censored in the numbers 0 to 6. And then in week 4, we have a quality of life 3. Then we have a quality of life 3, quality of life 4, 5. And then at 8 weeks, the patient had a stroke. At 9 weeks, the patient died. So that's what your data look like with that series. What if the MI status was unknown at 7 weeks? Well, the start of this is the same. You've got quality of life level 1, 2, interval centered 0 to 6. Then you've got a 3, 3, 4. And now at week 7, if they didn't have an MI, we actually know that their quality of life is a 5. But we didn't assess the MI for some reason here. So you could say this is interval censored from 5 to 7. And then you have an 8 or 9 complete observations. What we actually know is what goes into this point is either a 5 or a 7. It cannot be a 6 because we actually know it's a 5 if you don't need to override that with an MI. So you would actually use this kind of censoring. We know it's a 5 or a 7. And if you wrote customized software, you could actually handle that. But the software that we have, it needs the censoring to be contiguous. So we would just put this as interval censored at 5 to 7, and we're not far off. So you can see you can make use of exactly what you know, and you take into account what you don't know. And you can go further. The first 200 levels could be a continuous response variable, and the remaining values represent clinical event overrides. And so the statistical model that would be useful for this would be a proportional odds ordinal logistic model with covariate adjustment. And you handle one way to handle longitudinal nature of the data, because you have multiple records per patient, is to have random intercepts, mixed effects model for the patient effects. And this is an extension of the binary logistic model and the Wilcoxon-Mann-Whitney two-sample test. And it makes no assumption whatsoever about the distribution of the outcome variable for a given type of patient. And it doesn't use the numeric values. So when we saw these numeric values back here, those numbers are not used anywhere, only their order is used. So this could have been A, B, A to F, whatever 6 is. This could be a C, C, D. You could put letters of the alphabet so that the numbers are not actually used anywhere in the calculation. It just uses which category is higher than which. And so how would you interpret this? Well, you would get an odds ratio from the proportional odds model that people have to learn how to interpret better, or you can translate that odds ratio to the probability that a randomly chosen patient on treatment B has an outcome that's worse than a randomly chosen patient on treatment A. So this is a concordance probability. This is exactly what goes into the Wilcoxon test. And you can calculate that from the odds ratio from the proportional odds model. And there's a blog article that goes into this and shows that this does not assume proportional odds to be able to calculate this quantity. You can also calculate the probability that the patient will have outcome level little y or worse as a function of time or treatment. And you can compute this probability that death is affected differently than the non-fatal endpoints or other hypotheses. So this is the way we would favor presenting this, and clinical input is really needed here, but I think it's very, very intuitive. So we have here week going across, and then we have the probability of the outcome. So what's the probability of being in a certain state on a given week and a given treatment? So we have treatment A and treatment B. This is the probability of being hospitalized or worse as a function of time. And so hospitalized or worse means hospitalized, MI, or death. This is the probability of having an MI or dying as of a given time. This is the probability of dying as of a given time. And so by stating this for all the different cutoffs of the Y variable, you're showing cumulative probabilities of outcomes. And I would submit that these probabilities are easier to interpret clinically than most of the other things we're currently looking at. But just shows how you can do it for various levels of an ordinal outcome.
I have a few questions.
Yeah.
Can I interrupt?
Yeah.
The first thing is there anything unique about a Bayesian approach to evaluating the ordinal outcomes that you can do this model in a frequentist approach as well, right? Is there some greater flexibility you gain by
yeah, the Bayesian approach means you can interject skepticism about the treatment and you don't have multiple comparison issues. And also you get exact inference, whereas in the frequentist world, we can get pretty accurate inference, but it's not exact. It requires a lot of approximations that Bayes doesn't need.
And then it's really nice to capture multiple events for a person and, basically mirror their clinical course. But if you have a population where, a study population where most of the patients do not have events, they have good quality of life, but then you have a very small segment of the population with repeated events, how does this model kind of misrepresents clustering within patients? Part of just, time to event is you at least are able to apply it more to a person level, I guess. So how do you handle that clustering of multiple events within just a few portions? Yeah,
it's a great question. So there's sort of two answers to that. One is in the heart failure studies that don't take into account repeated hospitalization, there's a European Heart Journal article that's wonderful that just shows a huge loss of power. And you could have a much smaller sample size if you used all the hospitalizations. But as you were saying, there are certain events that once the event happens, it can keep happening. There might be a certain arrhythmia you're studying as an outcome. And once it triggers, you just never get rid of it. And it just keeps recurring in a kind of a redundant way. So in that particular case, you might need a way to not keep counting it. And you might have sort of a clock reset to qualify before you count it again. So there are some complexities you would need to deal with to handle what you said.
And then my last question, sorry, was, I don't know you've discussed this like on social media, but what about proportional odds violations between the levels in the ordinal scale? That, what if the odds are not proportional
Yeah,
for
that's
between
this last
events?
point here is getting at exactly that. This would be where treatment doesn't follow the proportional odds model with regard to death. And so by having a Bayesian parameter for that and having a prior distribution for how different you think the treatment could affect death versus affect MI, you would need to elicit a prior for that. Once you have that prior, you're borrowing information from MIs to learn about death. If you refuse to borrow information, then you're going to need a bigger sample size because you're going to need to have enough deaths all when it's on. But this would be using the partial proportional odds model to relax that proportional odds assumption, exactly like you would in a Cox model to relax the proportional hazards assumption with a time-dependent covariate.
Okay, thank you. I think Andrew might have had a question. You want to hold it?
Yeah, if you don't mind, it's about the, like Frank, this is great because I've struggled a bit sometimes to think of how to come up with good, effect size measures to convey this stuff to, when we have these more complex endpoints. And the one thing I wanted to ask about here is actually the sort of the probability, probability B greater than A, actually. No, still on that slide. Trying to, because there's something that actually sounds great to me about saying, like, well, look, this data suggests that you have a 97% probability of a better outcome with B versus A or something like that. But what occurred to me a little bit, and maybe this is just because I haven't grasped it quite right, is almost, is there a way for us to have uncertainty around that probability from a particular set of data? Like, it's almost like if you're trying to present that as your measure of effect, it's like based on this data, we're saying that you'd have a 97% probability of a better outcome with B than A. How can we also sort of incorporate uncertainty into presenting that? Does that make sense?
It makes total sense. So in the Wilcoxon test, there's a formula for the standard error of this estimate. And so you could use that directly. In the Bayesian world, you would get an exact credible interval or highest posterior density uncertainty interval for that, because you have a credible interval for the odds ratio. And then you just use this formula that'll automatically give you the credible interval for this probability. So
Great,
the Bayesian uncertainty assessment is a little easier than the frequentist one, but you could do it either way. It's an important point. Covariate adjustment is a totally different topic from what I'm talking about now, but it relates to our goal of decreasing sample sizes or increasing power and precision. And the first lesson to learn about covariate adjustment is it has absolutely nothing to do with baseline balance across treatments. It has to do only with the outcome heterogeneity within a treatment group. So to what extent do patients on treatment A have a different tendency to die because of various risk factors, including age? And so adjustment for strong baseline prognostic factors increases power for free. And so not using covariate adjustment is like shooting yourself in the foot. You have a gift staring you in the face that costs nothing, and you elect not to use it, so you're gonna have to raise your sample size between 10 and typically between 10 and 30%. And so you're getting the outcome model more correct. So you're realizing that older patients die sooner. So to ignore the age is wrong. You're realizing that patients with poor baseline 6-minute walk test have poor post-treatment 6-minute walk test. So not to use that baseline measurement is going to have unobserved heterogeneity in the outcome, and that lowers your power. The other beautiful thing about covariate adjustment is we talk about precision and personalized medicine all the time, but we don't do the simple things necessary to bring it to life. So the simplest thing you can do with precision medicine is to recognize that different patients have different tendencies to have the outcome, and you can provide estimates of efficacy for individual patients by addressing this. So the fundamental question of a parallel group clinical trial is, if I compare two patients who have the same baseline variables but were given different treatments, by how much better should I expect the outcome to be with treatment B instead of treatment A? So that's really all about precision medicine. So taking into account covariates And making your treatment assessment covariate specific is a way of personalizing the results of the clinical trial that you can get for free, and it doesn't even take omics to do that. You get a correct basis for analysis of heterogeneity of treatment effect. And if you instead decide to do subgroup analysis, that's going to be very misleading, and it doesn't inherit the proper covariate adjustment. I think that was a Twitter topic earlier today. And subgroup analysis does not properly handle continuous variables. And then this is kind of a side sermon, is don't compute change from baseline. So if you find yourself in a parallel group study ever computing change from baseline, heaven forbid you would actually use it in a statistical test, but just the act of computing it means you don't understand regression to the mean, you don't understand measurement error, you don't really understand what a parallel group design means. So if you're going to use change from baseline, which is the post minus the pre-treatment measure, there's a lot of assumptions that have to be true before you would even feel halfway good about using that difference. The post has to be linearly related to the pre. So if you're using like post-treatment ejection fraction versus pre-treatment, the slope of the post and the pre has to be 1. So if one of these things is not true, it is not correct to calculate the change from baseline, much less use it in a statistical test. The analysis of covariance doesn't assume either of these. If your baseline is totally irrelevant, you'll get an estimated slope of 0, close to 0 in analysis of covariance, and it will properly ignore the baseline. Analysis of covariance can allow for nonlinear effects. So the post minus pre is inconsistent with a parallel group design. It's something you would only use in a pre-post design, which is the weakest of all possible experimental designs. And the post minus pre difference is easily manipulated by patient inclusion criteria and regression to the mean. So there's some take-home messages. One message is don't take sample sizes seriously. This is sort of a habit we've gotten into of believing sample size calculations and believing they're necessary. NIH has made them largely necessary because NIH wants you to have fixed budgeting, and NIH doesn't want to redistribute money if you find out that something is not promising early. Stop the study earlier and redistribute the money. Investigators probably don't want that either. NIH doesn't want you coming back and asking for more money after this planned end of the study, but it would be logical to do that. If you're working at a pharmaceutical company, they have no problem at all with these ideas because they do internal budgeting. Alpha is not a relevant quantity to control or spend because alpha is really unrelated to a decision error. And the errors we care about are not assertion events, such as rejecting a null hypothesis. The error we care about is a decision error. And so we need to calculate the probability of a decision error, and that needs a Bayesian method. We need to choose a high resolution, high information outcome variable and break the ties to the extent possible. If you write down your problem as a longitudinal ordinal study design, that's a very general and flexible way to capture severity and timing of outcomes. So that handles time to event analysis, it handles functional status analysis, quality of life, it handles recurrent events like hospitalization all in one model. And then always adjust for strong baseline prognostic factors. And as a side comment, don't even stratify by treatment in table 1. It'll get you into nothing but trouble. So I really appreciate everybody listening. Look forward to see if there's other questions or discussion.
Thank you so much, Frank. That was simply fantastic.
Thank you.
Yeah, thanks, Frank. I was going to ask your thoughts on what is the resistance to, integrating some of these more modern methods and even just like basic covariate adjustment a priori into trial designs. We just don't see it in the published literature. And I would think that industry would, be the first to sort of adopt this because it saves you money, to decide when a trial is, is futile to proceed, or if you're very close to be more adaptive about your structure to recruit a little bit more. And so what's been the challenge in actually seeing this more commonly in the literature for how trials are designed?
I've been really racking my brain to find out what's the source of resistance, and I still haven't completely figured it out, but some observations are the literature sort of perpetuates methods. So methods get used because they were used already in the literature or in a certain journal. Journals have done a very poor job in leadership for modern methods, horrendous job. And so it's sort of a self-perpetuating thing. And then what are we teaching? And so if you look at how clinical investigators are taught, they're taught a lot of classical design. They're not taught a lot about ordinal outcome measures. They're not taught a lot of Bayes or sequential designs. And then how are statisticians taught? They're not really taught Bayesian methods. They're not really taught likelihood methods. They're mainly taught frequentist methods, and they're not really taught what frequentist methods truly mean. Many of them can't even define what alpha really deeply means. So I think we have this combination of things, and then I'll just finish it by saying the physicist Max Planck was asked about this, and he said, people don't change, they just die and they're replaced by the next generation.
Well, not sure the next generation has caught up to all this yet, but hopefully you're blazing a path still. So that's pretty amazing.
I will say, if I can chime in for 1 second, sorry, because I'm obviously an oddball guest here, sort of a Frank fan from Twitter in the world of statistics. But I think for Frank's part, and for your part, I think inviting Frank to give a talk like this is part of how we get that change, right? We statisticians have to come meet clinical investigators and future clinical investigators on their turf. Otherwise, we end up kind of, siloed, statisticians developing great new methods and things like that on one side, and, clinicians who have never heard of this stuff on the other side. And I think that, getting on Twitter for myself and for some of these other folks is a way that you even become aware that these things are exist, right? Like I have conversations sometimes with people who have never heard that you're allowed to covariate adjust in a trial. If anything, they actually think it's cheating. They think you're not supposed to do it. And, so I think that what you did here in bringing Dr. Harrell to give this talk is great, because I think that's part of what we need. It is, like you said, that next generation has to get exposed to these ideas while they're still kind of in training, because, by the time people are, fairly senior folks know, like, oh, I've already done a bunch of trials, I know what I'm doing, I don't need to do it this other way. And of course, then there's the separate side that Frank would probably talk about, which is culture change at places like NIH and FDA. Which I'm sure he has plenty to say about as well. But I think what you did in bringing him for this talk is great, because I think that's one of those critical steps in getting this to happen.
Thanks for stroking my ego. Pay you later.
We agree. This is fabulous.
I appreciate
Frank,
those observations, Andrew. And I'll just add that I think it's our job too to really go, as you said, Andrew, to the clinical investigators, to teach them to be impatient with their statisticians. And that's the way I teach clinical investigators at Vanderbilt when I teach the Biostatistics 2 course in our Master of Science in Clinical Investigation. We teach them a little bit about bootstrapping, multiple imputation, nonlinear flexible regression, and they learn how to do all these things. And one reason of many is so that they're working with statisticians that haven't moved to the more modern stuff. They will be impatient with those statisticians and kind of drive the statisticians to do better.
So one of the potential barriers is, so ingrained the concept of pre-specification, and we've seen so many examples of where secondary, tertiary endpoints get emphasized and then aren't replicated. And so how to address that sort of concern? I mean, when it comes to covariate adjustment, people feel like the order in which the variables are entered, even if pre-specified, can sort of be manipulated to get the result that you ultimately want. So how to build that rigor around preserving some component of pre-specification when you're constantly looking at the data till it gives you the answer that you want.
So that is actually the easiest problem to solve. It may not sound like it, but the way you solve it is you never use the word enter. And so the models are pre-specified and they're just laid out. All the terms are laid out. They're completely specified except for their coefficients. And you don't ever entertain the idea of possibly entering more or fewer variables than that. And so this is pre-specification is really important. And the only thing that I really don't like to pre-specify is the sample size.
And Frank, I have a follow-up question on that. I really enjoyed your talk. So in terms of pre-specifying the covariates for adjustment, what would you suggest is the best approach in terms of how many, or deciding? Obviously, they'd all go into the pre-specified model, but do you have any concerns about how many or how strong or what to base the prior evidence on? So any of the sort of prior knowledge?
Just a really rough rule of thumb is you don't usually need more than 5 covariates, and sometimes use fewer than that if you have a smaller study. And so we have some very rough rules of thumb for what's the maximum number of covariates, but generally you don't need more than 5. And it depends on whether you have like a very dominating covariate. Like if you're looking at a function measure after treatment and you measure that same thing before treatment, that'll be a dominating covariate. You may not need many others. And so, but it's really based on clinical knowledge in the literature. And most clinicians that I've worked with over the years are really good at knowing what the important prognostic factors are. And the thing that I have trouble with is there are statisticians who would say that if your model doesn't fit the data, you shouldn't use it at all. And then I say to them, well, your approach is to assume that all the covariates have a 0 effect because you don't believe in adjusting for anything. And that's the worst fitting model you'll ever see in your career, is assume that age doesn't matter on mortality. And so I try to kind of give them a gentle ribbing that the method they want to use makes the most assumption, and the covariate adjustment doesn't have to be close to even being perfect to be highly effective.
Okay, thank you.
Any other questions? That was really excellent, Frank. Thanks for taking the time and putting this lecture together. And yeah, definitely follow Frank on Twitter. And I just learn a lot just by reading, other conversations you're engaged in. And sometimes we'll ask for your insights on various topics. But this has been a terrific lecture, and hopefully people got some nuggets for thinking about before planning their next study.
I really appreciate the invitation, Bobak. It's great being with you. Great being with you too, Andrew. And I really thank you all for having me. And I learn a lot from Twitter too. And one thing I learned is how people react to various things that I put out there. So I always look forward to that. And I'm always getting corrected about certain things, but over time, hoping to do better and have a more complete understanding. See you
Thanks,
later.
Dr. Harrell.
Thanks.